Hello guys, hope you are all doing well. Continuing with our GI surgery series, today is part 2. Yesterday we began with esophagus. Let's do some more of esophagus today. We have some interesting clinical image based questions lined up. So let's see how you guys can handle it today. Right? Okay, you can message in the chat box. I can see your messages, guys. Okay, great. So while people are joining in, let me tell you a little bit about myself and our platform. So I am Dr. Amrit Nasta. I am a bariatric surgeon from Mumbai and I am your surgery educator on the Unacademy platform. If you wish to learn more from me, please download the Unacademy learning app where you can follow my profile and the profiles of other educators like me who will help you prepare for all your upcoming entrance exams. So we have different educators for different subjects who will help you, who will guide you. All you have to do is download the app, follow us. If you follow my profile, you will get updates about my upcoming special classes, YouTube classes and so on. On the Plus platform, to help you prepare with your exams, a lot of batch courses have just started. They are all focused courses. Depending on the exam you are targeting, you can join them. Whether you are appearing for NEET PG 2021, which is going to be this year or next month, or entrances next year, or INI-CET, and so on. So there are different specially curated courses, short duration courses, which will help you with your preparation. So if you have less time, these are the courses you should attend. Remember, this is the course, this is the code to use, that is 10 surgery. This code will get you a 10% discount on your Plus subscription. So these are some subscription models that you can opt for. Apart from that, there are a lot of free things which you can attend. Definitely you should attend my free YouTube videos which I take regularly, special classes which I take regularly. They are all free of charge. And of course you should take benefits of all these test series. Some are daily tests, some are weekly tests. There is a grand test series. This grand test series is like a NEET PG mock test. So 200 questions, clinical pattern questions. You should definitely attend and give them. The last one was on March 7th. There will be every Sunday, there will be one test series. Okay, so make sure you make full use of these free things on the app. And of course, if you want comprehensive learning, there are two subscription plans. There is a Plus and an Iconic. Plus gives you benefit of live classes but with a much smaller audience. So you get better interaction. You have access to the batch courses I was talking about. Or you can take the Iconic subscription. Now, Iconic subscription minimum duration is 1 year. There isn't a shorter plan. So this you should only take if you are appearing next year. Right? This has Plus and Prep Ladder. Dono ke benefits are there. So Prep Ladder gives you video lectures, handwritten notes and so on. Whichever exam you are targeting, this year or next, think of a subscription plan accordingly. So if you are taking 12 months, 18 months, remember this is the code to use, and that is 10 surgery. That will get you a 10% discount. If you're taking a smaller subscription plan, don't worry, it's the same. This is the code, 10% discount. So if you are appearing next month, or 1 month will be enough. If you are appearing for INI-CET, 3 months should be enough. Right? So think about it, depends on your target. Okay, so let's come to today's class. Yesterday we did a few questions on esophagus, some interesting things. If you have not seen yesterday's class, please go through it. We discussed GERD yesterday. Interesting things we learned, intra-abdominal length of esophagus and many more interesting things. Fundoplications, those were the things we did yesterday. Today we'll go one step ahead. We'll do some other topics in esophagus. Let's see how you guys can handle today's class. Okay, this is a new question. It has never been asked before. Okay, this has never been asked before. Let's see if you have ever seen something like this. As an intern, you should have seen something like this at some stage. Maybe. Okay, maybe you would have seen something like this as an intern. But once you see it, you can never forget it. So, following radical esophagectomy, patient develops breathlessness on post-op day 5. A chest X-ray is done. Patient has left-sided pleural effusion. Intercostal drain is inserted and the fluid that is drained looks like this. Okay, it looks like this. What will you send this fluid to confirm the diagnosis? So understand, you've had an esophagectomy. Patient has pleural effusion post-operatively. You want to know the cause of the pleural effusion, right? It's not normal for someone to get pleural effusion post-operatively. नहीं होना चाहिए. There are many causes. Probably the fluid which was aspirated, it looked like this. This is the intercostal drain bag apparatus. Okay, this is not your normal ICD bag. It's a different one. It is a dual intercostal drain bag. Okay, very good, excellent. I am so happy you guys are thinking practically. These are the kind of questions you should expect. Sir, still in final year MBBS? Yes, Pravesh. Very well, I know. This requires some amount of expertise to solve these kind of questions. So I am happy you guys got this. Absolutely right. This is chylous effusion or chylothorax. Why are you calling it chylous? Why are you calling it chylous? Chylous क्यों है? What is this classical appearance? And chyle means what? So this is milky white. Please understand, pleural effusion which is milky white means it is rich in fat. Means it is probably chylothorax. Okay. What is the role of doing fluid ADA levels? When do you do this? Yeah, Sandeep and Mukhtar, you're right. Milky white. When do I do fluid ADA levels? What is the benefit of doing fluid ADA levels? When should I do? Would I do it in a post-op day 5 patient? Fluid ADA levels. कभी करते हैं क्या pleural fluid का ADA levels? ADA is adenosine deaminase. I hope someone in pathology has covered these things for you. Or in medicine, this is not purely surgical. Excellent, absolutely right. This is a feature of pleural effusion due to tuberculosis. So tubercular pleural effusion, absolutely right. Mind you, this is not specific. If I want to confirm tubercular pleural effusion, what should I do to the pleural fluid? If I want to confirm that the pleural effusion, let's say the person's ADA came high, does that mean he has TB? Or I should do something else with the fluid? Yeah. This is how questions are going to be built. Huh? You have to know one step, next step, next step, next step. Like if the question changes, pleural fluid ADA was say 100, normal is up to 30-35. Okay, let's say it was 100. Does that mean what will be the next step? They'll give you some investigation or they'll say let's start ATT. Culture. Okay, Charmi says culture. If you want to confirm your diagnosis, one thing you can do is gene expert. Absolutely right. And other is cell culture, also called as BACTEC. We call it BACTEC. Okay, not gamma interferon, BACTEC or CBNAT. Right. So these are some of the ways of confirming tuberculosis. Chylomicrons, understand, this pleural effusion or chylothorax implies thoracic duct injury. Now your thoracic duct is the main duct which carries all the lymph. Lymph is nothing but fats and proteins back, and it drains eventually into the jugular veins or into the subclavian veins. It drains into the venous system. If this duct gets injured, which can happen in radical cholecystectomy, all the chyle will start leaking out. Commonly you get left pleural effusion. Okay, commonly you will get left pleural effusion. That is because the chyle is lost. Chyle or fat, proof of fat is going to be chylomicrons, no doubt about it. Chylomicrons will confirm. When will I send bile salts or bile pigments? When will I send pleural fluid for bile salts or bile pigments? When will I send this? Will I send it in a post-op day 5 patient is what I am trying to ask you. What will I suspect, if anything, which will make me think, okay, let's send it for bile salts and bile pigments. I'm not very happy. Yeah, any idea? First you need to know radical esophagectomy के बाद हुआ क्या है. because of which there may be bile salts or bile pigments in the pleural fluid. It won't look like this, huh? It will look very different. It will look very different. It may be greenish. Okay, it may be greenish, it may be golden yellow. So if this fluid was greenish looking, liver abscess rupturing into the pleura. No. Post-op day 5. I'm asking you in this context. Post-op day 5. Will I send? So, patient had pleural effusion following radical esophagectomy. Post-op day 5, you did X-ray. You aspirated and you said the fluid is greenish. Let's send it for bile salts and bile pigments. Why? How can there be bile salts and bile pigments in the pleural fluid? Any idea? Is it possible? Yeah. Diaphragm injury, no. Esophagectomy में diaphragm injury का क्या connection है? And liver abscess, no neural. I'm talking about this scenario. And I'm asking something very specific. Fever associated or jaundice. Why will there be jaundice after esophagectomy? कोई connection है? बिल्कुल ही नहीं है. I'm telling you ना, there is a greenish fluid which is collected in the pleural space. What is this greenish fluid? And what bearing does it have in a radical esophagectomy patient? Aha, not thinking. Bile salts, bile pigments means it is coming from intestine. अभी intestine कहाँ से आ गए pleural fluid में? It means it can be an anastomotic leak. It can be an anastomotic leak. Understand, whenever I do a esophagectomy, I am going to do an esophagogastric anastomosis or an esophagojejunar anastomosis. कुछ तो join भी करूँगा ना. So when I do the joining, when I do the anastomosis, what if the anastomosis leaks? If the anastomosis leaks, he will have bilious pleural effusion. Bile salt, bile pigments will confirm. Malignant cytology not in this bearing. It's not going to be in post-op day 5. So that has no bearing in this case. But these two definitely can be a cause of post-operative pleural effusion, especially post-op day 5. Okay. How do I confirm? So let's do two things over here. One is chylothorax, which I told you. Chylothorax means thoracic duct injury. And thoracic duct injury will give me chylothorax or chylous effusion. How do I confirm that the thoracic duct is injured? One thing is the pleural fluid I send for chylomicrons is, what if chylomicrons are negative? Is there anything else in the pleural fluid which will tell me it is chylothorax? What? Because chylomicrons is the most specific marker. But is there anything, any proxy? Achan Khan ji, good evening. Yes, good evening, Achan. So chylomicrons in the pleural fluid is most specific of chylothorax. पर कभी-कभी chylomicrons detect नहीं होते. Sometimes you don't detect. Is there any proxy marker which will tell me it is chylothorax? So when do you do esophagectomy? You do jejunal. So why don't you join stomach? No, we will come to that. There are many ways of doing esophagectomy and reconstruction. We will come to that. Don't worry. One of the reconstructions is esophagojejunostomy. One of them. You can do esophagogastrostomy also. But we will discuss them later. The test says triglyceride. How much should it be? Triglyceride should be more than how much? Chylomicrons present. Only present is enough. How much should be the triglyceride? Triglyceride, you need a level. How much should be the triglyceride? To tell you it is probably a chylothorax, it should be more than 110. Okay, chylomicrons present or triglycerides in the pleural fluid more than 100 or 10. What is the investigation of choice? Charmi, not 200, 110 is diagnostic enough. What is the investigation of choice? Okay, but अलग-अलग answer है, 200, 150. Investigation of choice to confirm chylous effusion or chylothorax. Yes, any idea? Investigation of choice. How do I confirm that the thoracic duct is injured? And that is why the chyle is going into the pleural space. these are the kind of topics which we normally don't study, but they have a lot of clinical bearing. CT. CT of what? CT. किस चीज का CT? MKK. Yeah, CT of what? CT thorax. It will only show pleural effusion. HRCT won't show anything. I have to show that the thoracic duct is injured. CT of what? किस चीज का CT करूँगा मैं? So ऐसे जा रही है. Thoracic duct. Sorry, it goes on the right side. Thoracic duct is on the left. Okay, and then it goes into the abdomen. How do I confirm the thoracic duct is injured? No, chylomicron only presence. Only presence. If it is present, it is diagnostic. Don't have to get any level. Lymphangiogram. Which lymphangiogram? Okay, I will give you option. Investigation of choice. CT lymphangiogram. CT lymphangiogram. MR lymphangiogram. Conventional lymphangiogram. See, you give one answer, I will give you 10 questions. Or lymphoscintigraphy. Lymphoscintigraphy. Chalo, now you have 4 options. Now pick one. CT lymphangiogram, MR lymphangiogram, conventional lymphangiogram, or lymphoscintigraphy. And let me tell you, all of them are totally different. Huh? सब अलग है. ऐसे मत बोलना sir, they all same like the other side lymphangiogram. Investigation of choice. Sandeep says lymphoscintigraphy. अच्छा. Not conventional lymphangiogram. Mayuresh is laughing. Wow, Mayuresh, all 4 sound the same, isn't it? Yeah, your exams got postponed, I heard. That's why you are happy. Let's come and attend. Nurel says A. MKK also says A. Okay. So let's be very clear. If they ask you investigation of choice, it will be between one of these, CT and MR lymphangiogram, because they are non-invasive. Absolutely. My answer would be MR lymphangiogram. अगर दोनों ऑप्शन में दिए MR is going to be better than CT. Okay, if only one of them is in the option, whichever is there you go for that. But अगर दोनों ऑप्शन में, my answer would be MR lymphangiogram. If they ask you best investigation or gold standard, then it is conventional lymphangiogram. Conventional means what? You have to cannulate and then you inject the contrast, like how you have DSA for arterial disorders. That is conventional lymphangiogram. If they ask you most sensitive, it will be lymphoscintigraphy. This is not done by radiologists. This is done by nuclear medicine. It is lymphoscintigraphy. Okay, most sensitive. This is a bit like HIDA scan. How you do HIDA scan for gallbladder and biliary? Like that, your lymphoscintigraphy, gamma camera. Okay, so they are all totally different. Investigation of choice is usually CT or MR, usually. Okay, but best conventional lymphangiogram, you can diagnostic and therapeutic. Most sensitive, a scintigraphy. A nucleotide imaging is the most sensitive imaging when it comes to leak. Okay, here it is thoracic duct leak. So when you are talking about leak, most sensitive will always be a scintigraphy. They asked something similar in INI CET in November. Okay, so someone was asking, why not jejunum, why not stomach? So see, I know what your doubts are. I have made the question ready for you already. Best conduit to replace esophagus following resection for malignancy is best conduit. Which means when I do an esophagectomy, okay, right, I have to re-anastomose so that the person is able to eat again. So I need to bring something in place for the esophagus. What is the best thing to bring in place? Stomach, jejunum, transverse colon or sigmoid colon? What is the best esophageal substitute? I got A, B, C. सारे आंसर आ गए. A भी आया, B भी आया, C भी आया, jejunum. Okay. Jejunum is the best replacement. Noral is also saying jejunum. And MKK is saying transverse colon. Oops. Let us try to visualize what's happening. I have removed the esophagus. थोड़ा मेरे पास ऊपर esophagus बाकी है in the neck. Rest all of the esophagus is gone. And I need to bring something in its place. By common sense, what should I bring in its place? Common sense. Now don't think about the options. You think about common sense. What is right there that I can bring in its place? सारे आंसर आ रहे. Stomach, jejunum, transverse colon. कोई sigmoid colon भी बोल ही दो. Mayuresh, I hope you have not written transverse colon in your theory paper. I hope not. What is right there that I can anastomose to the jejunum? कमाल है. Answer is stomach. Yes, stomach, pullen joint. Stomach, it's closer. Stomach, it's vascular. So what I do is, after I am done with the esophagectomy, I make a tube of the stomach. Okay. Lesser curvature wala part I remove. I remove this part like this. Okay, this is removed. Stomach along the greater curvature is made into a tube and this is pulled up. So what I do is I do a esophagogastrostomy. On what vessel will the stomach survive? Yeah, easily mobilize, absolutely right. Very easily mobilize is right there. You have a big stomach, just make a tube and pull it up. On what blood vessel will the stomach survive? It's like a, what do we call it? It's like a flap. In a way, it's a flap. जैसे हम flap करते हैं ना plastic surgery में. It's like a flap. I am taking the stomach to a distant site, pedicle flap. On which pedicle will it survive? Stomach, because it will prevent from megaloblastic anemia. I wouldn't say that. Gastroepiploic. Which gastroepiploic? So 4 options. Left gastric artery, right gastric artery, left gastroepiploic, right gastroepiploic. Common sense answer. It's common sense. You don't have to mug these things. In my class, you don't have to mug. This tubularized stomach will survive on which vessel? Because I am taking it away, pedicle flap. So it needs a vascular pedicle. Which vascular pedicle will sustain it? Gastroepiploic, right gastric, gastroepiploic. अभी ये 4 है. Now this is MCQ time. You have to pick one. A, B, C, D. Left gastric, right gastroepiploic, right gastroepiploic. It's all common sense. There is no mugging in this. Once you know your tube is going to be made like this, because this is the way I will get maximum length, isn't it? Very good. Understand? Left gastric and right gastric are along the lesser curvature. Okay, this will be left gastric artery. The left is up. This will be right gastric artery. Left gastroepiploic will be over here. This is left gastroepiploic. Right gastroepiploic will be over here. Now you can see it is the right gastroepiploic which is going to supply the tubularized stomach. So answer is right gastroepiploic. No mugging. Okay. Only thing you need to remember is this is how the tube is going to be constructed, and that is common sense because that is the way I will get a maximum length of the stomach. Maximum length तो ऐसी आएगी ना. अभी मेरा stomach ऐसा है in the body. I cannot get a tube like this along lesser curvature. This length will be not much. If I get a tube along the greater curvature, I will get much more length like this. A tube like this will have much more length, isn't it? Common sense. Right gastroepiploic is the answer. So best substitute. Yeah. But sir, won't gastric acidity cause distress to patient in esophagogastrostomy? Of course it will. No doubt about it. But you have a lesser stomach over here. So the acid production will be less. The effect will be less. And you have no choice. No choice. This has the best functional outcome also. So best substitute, stomach. If by chance, let's say the tumor is at the GE junction. Okay, it's an aggressive tumor. I can't use the stomach. Stomach बचा ही नहीं है. I have to do a lot of gastrectomy also. Then what is the next best thing? If I can't use the stomach, what else can I use as a conduit? Next best thing. Because it's a lower esophageal malignancy, which are very common nowadays. So I can't pull it up. If I can't pull it up, what can I use next? Transverse colon, absolutely right. And the last is jejunum. Okay, this is the system. This is the sequence. Please understand. Stomach, transverse colon, jejunum. It is going to go in that sequence. So Mayuresh, this was the answer. I have taught this to you before. Okay. All right. Important question. Important image. What investigation is this? Never duodenum, because duodenum does not have its own vascularity. It shares its vascularity with pancreas, so I cannot pull the duodenum up. Right? So what important investigation is this? You have to be able to identify this. Is 24-hour pH study, manometry, echo, or virtual esophagoscopy? I didn't see that option. I hope that didn't happen in your exam today where you didn't see options. I hope not. Very good, excellent, excellent, absolutely right. This is esophageal manometry. So how do you identify it's a manometry? Please don't look at this. Whenever you are given any graphical image, whenever you are given any graphical image which you can't understand, the way to understand is read the units or the calibration. Many times the units or the calibration will tell you what the image is. You see over here, यहाँ पे है ना calibration. You see the colors which are calibrated. What do you read over here? I'll try to zoom in a bit. इतना ही दिखता है एग्जाम में. Your exam images are like this only. Okay, इतना ही आपको मैग्निफिकेशन मिलेगा और इतनी ही क्लैरिटी मिलेगी. Those who gave INI CT, they said sir image quality बहुत बेकार थी. What is written in the calibration? Yeah. Let me see if any one of you could identify it. What calibration is this? Once you have these concepts clear now, whatever image they throw at you, you will be able to identify. Yeah, what is this calibration? In what units is this graph graded? It's blur. उतना ही है, blur इतना ही मिलेगा. ये क्या सर्कल किया है मैंने? Values नहीं है ये. Exam में इतना ही आएगा. So don't say it's blurred. Aisha. Yes, this is mm of Hg. Mm of Hg. Mm of Hg has to be manometry. So any imaging where it is mm of Hg and graphical, it is manometry. और क्या होगा? What is this axis showing? Now वो लिखा नहीं है इसमें. I'm just asking you out of curiosity. This axis is showing pressures. So the colors represent the different pressures. Like yellow, green, it is this much level of pressure. Pink, red is a higher pressure. That means in this area the pressure is high. What is this axis? मतलब यहाँ क्या है, यहाँ क्या है और यहाँ क्या है? What are these things representative of? क्या फायदा फिर इतनी सारी फीस तो लेते हैं इंक्लूडिंग जीएसटी. उनके पास फीस है लेकिन टेक्नोलॉजी इतनी नहीं है. अभी तो तुम्हारी एग्जाम में जीआईएफ्स और वीडियोस भी आएंगे दतेश. दे विल गिव यू, दे विल बी अ पेशेंट एंड द सर्जन विल बी डूइंग सम टेस्ट एंड दे विल आस्क यू टेल द साइन. ऐसा भी होगा. गॉड फॉरबिड कैसे वीडियोस होंगे वो. इंटरवल्स. व्हाट इंटरवल्स? What is this? What is this? What is this? What do these areas represent? Distance along the esophagus. Excellent. There are two components. One is time and other is segment of esophagus. Segment of esophagus, and they go hand in hand. Right? So this probably is body of esophagus. Probably. This probably is distal esophagus or maybe LES. Probably. So this area tells me that LES, the pressure is very high. So high hypertensive LES, irregular contractions, probably this is achalasia. Okay, I am just giving you a little brief approach on how to read an investigation like this, which you would have never read otherwise in your life. They will not ask you to diagnose. Okay, they will not ask you to diagnose, don't worry. But you need to have a concept. This is the other imaging. This you would have never seen in your life because this is not very commonly done. This is 24-hour pH study. Okay, this is what I want you to look at more carefully. Because ye hide. Never asked. This is hide. Never asked if the person who is setting your questions does upper GI surgeries, he will know about this. ओके अगर वो मेरे जैसा बेरियाट्रिक सर्जन है तो उसको नहीं पता होगा पर अगर वो अपर जीआई सर्जरीज करता है फंडोप्लाइकेशंस एक्लेसियास ही विल नो दिस सो यू विल पुट दिस नाउ हाउ डू यू अंडरस्टैंड इट इज अ पीएच स्टडी अगेन see the units. Needless to say, you can see the unit over here. I don't even need to magnify it. Clearly you can see it. What unit is this? Which I have marked. ये image blur नहीं है आयशा. This you can clearly see. What unit is this that I have marked? And this you can clearly see. This is time. This goes 11 a.m. Maybe 6 p.m. Maybe 3 midnight, 3 a.m. Maybe 11 a.m. This you can see is time. What unit is this? Yeah. Any idea? You see this, you will never have a problem in understanding what's happening. Yeah, absolutely. This is pH. So you see pH, you know it is a 24-hour pH study. और तो कोई टेस्ट है ही नहीं जिसमें pH करते हैं. You can see 0.5, 1, 2, 3, 4, 5 up to 8.5. That is the pH they are expecting. That is part. Other part is the time. Now what do you need to see in this? Okay, what do you need to see? This big white line that you see, these big white lines that you see, these lines signify when the patient presses the button. When the patient presses the button, okay, that is when he feels the symptoms. So when I do a 24-hour pH study, what do? I put a catheter through the nose and at the GE junction. It is attached to a recording device, and on the recording device there is a button. So what the patient is told to do, he has to wear the device for 24 hours, and whenever he feels acidity, reflux, he presses the button. Okay, he presses symptomatic reflux. Also, ये जो red lines है, those lines are the recordings of the pH probe. Okay, those are recordings of the pH probe, means what is the actual pH at the lower esophageal region. So you can see over here at maybe say around 11 o'clock, 11 a.m. the line went all the way down. That means the pH was very low. Again in between somewhere at 3 o'clock the pH went very low. Same thing happened at 6 o'clock. Same thing happened next day early morning. So these are the times where the pH was actually low. And the patient also felt the reflux. So what are they doing? They are comparing. What are they comparing? They are comparing two things. Patient symptoms, when is he feeling, with actual pH. So they are trying to match. Is he feeling the symptoms when the pH is actually low? If the two match, that means there is a good correlation. That means there is a good correlation. So understand, the 24-hour pH study is not a diagnostic test. It's a test to correlate the symptoms with the pH. It's a correlation study. How do you get this correlation? On what grounds do they measure this correlation? So this is not diagnostic, mind you. This is not diagnostic. This is a test which will correlate. It's not a severity test. It's a correlation test. How do I know there is good correlation? What is the measurement? Measurement is given by ये तो मालूम ही होगा. यही तो हम एमसीक्यू में पढ़ते हैं पर समझते नहीं है क्या है. Yeah, what is it called? Subjective. Yeah. This is not subjective. This is correlation of subjective with objective. How do you get the score? What is it called? it's the Demister score. Now, if the Demister score is more than 14 point something, that means there is good correlation. Yes, absolutely, it is gold standard. But mind you, gold standard is never a diagnostic test. Okay, it's never a diagnostic test. uh, when patient presses the button, does pH actually increase? And actually decrease. Mayuresh, not increase, decrease in pH. So when the Demister score is high, that means there is good correlation. That means the person actually has reflux symptoms because of reflux and not because of some other issue. Because many of us feel we have acidity, actually we don't. When we do endoscopy, it may be normal. What we feel is acidity, maybe something else. This will confirm GRD. Okay, very clear on this. It's a very high yield topic. Okay, very high yield topic. 24-hour pH study. It's fairly unexplored. आज तक इतना पूछा नहीं है. Okay, this question is asked last year. This was one of the difficult questions, if you ask me. This is NEET 2020. Asked last year. According to me, one of the most difficult questions of surgery in NEET 2020. Like, these are the kind of questions you can leave. Or you can leave if you want, you can take a guesswork. But not worth preparing for if you don't know from before. So patient with dysphagia to liquids undergoes manometry. Findings include absent peristalsis, high pressure LES, and spasms. What is the diagnosis? ये repeat है. This is not my own question. It's a fairly difficult question. Some D, some C. Okay. I will give you a clue if this gets repeated in some way or the other. Understand, manometry is the investigation of choice for motility disorders like achalasia. It is the investigation of choice. So when I do manometry, a lot of motility disorders get picked up. What on manometry tells me it is achalasia? First, let us understand, is this achalasia? Because if it is achalasia, then jackhammer esophagus gets ruled out straight away. And if it is not achalasia, I can straight away mark jackhammer esophagus. So what on manometry tells me it is achalasia? Yeah, anybody? Hallmark findings of achalasia. When do I say person has achalasia? On manometry, what should you get? This you should know. This is acceptably fine. मतलब ये तो मालूम होना चाहिए. हाँ, type 1, type 2, type 3 is थोड़ा high funda. Absent in body. So most important is poor or absent peristalsis in the body. Poor or absent peristalsis in the body. Okay, this is the first sign. So your esophagus is a mega esophagus, bird beak esophagus, where in the body the peristalsis is weak. So most important finding, most important, poor peristalsis. Second is, this is not always seen, but it is seen most of the times, is a high pressure LES, hypertensive LES. This plus this equal to achalasia. You get these two findings, it is 100% achalasia. No other motility disorder has both of them. So absent peristalsis, hypertensive LES, so it is not jackhammer esophagus. Straight away eliminated. Means it is one of the three. Now, how do we know 1, 2, 3 is में कौन सा है? If you see the word spasm, that means it is spastic achalasia. That is type 3. So type 3 achalasia is also called as spastic achalasia. Type 2 में क्या होता है? Type 2 में क्या होता है? If you know, good. If you don't, I will tell you. What do you see in type 2 achalasia? No food intake. Why would you say that? No food intake. Of course, he'll have food intake. Yeah. What do you see in type 2 achalasia? बस ये दो तीन चीजें आनी है. फिर कोई भी घुमा के MCQ पूछे, you will know. Type 2 eclasia shows what is called as pan-esophageal pressurizations. Excellent, Saurav. That's an excellent answer. Pan-esophageal pressurization. Bas. Type 1 will show none. None of these things. Bas. That's all you need to know. Pan-esophageal pressurization. Okay. This is what is given in the Chicago classification. Type 1, type 2, type 3. अपने को सिर्फ इतना चाहिए, spastic, pressurized, and neither. Just peristalsis. Aperistalsis. That's all we need to know. Okay. Yeah. Oops. Alright. This is a new question. I framed this today only. आज ही बनाया मैंने ये question. Let's see what you think about this. Following a binge of alcohol, a 40-year-old male presents with multiple episodes of vomiting and hematemesis. He appears to be intoxicated, but his vital parameters are stable. Nasogastric lavage confirms hematemesis. Endoscopy is likely to reveal. ये आज ही बनाया मैंने. I made this question today only. So you would have not found this in any of my earlier classes. Alcohol binge, multiple vomiting, hematemesis, intoxicated, he is otherwise fine. Nasogastric reveals. Okay, Sandeep says C, Nural says C, Hira also says C. Tear in lower esophagus. Datesh also says C. All my star students have come together after a long time. Good job. Good job. Charmi. Oh, Ria says D. Tear in gastric cardia. Ria, the odd one out. Nobody for A or B? Okay, it's not A or B because you saw what I had written. Unfortunately, this is the problem with the YouTube class. Alright. This is a Mallory-Weiss tear, no doubt about it. Alcohol binge, multiple episodes of vomiting. Let me tell you, Mallory-Weiss tear, 90% is gastric cardia. Oops. So, only Ria is correct. It is tear in gastric cardia. 90%, it's a mucosal tear in the gastric cardia. Lower esophagus, remaining 10%. Don't trust me, this is given in Bailey. आज ही बनाया मैंने ये पढ़ के. Bailey. This line is there in the esophagus में chapter में. Okay, so oops. Only Ria got it correct. Shame on all of you. Shame on Datesh who comes every day for my class, and Nurel who comes regularly for my class, and many of my other students. But this is what it is. That's why you are here. You learn some new things. Even I didn't know many of these things. I read it, so I came to know. Now, understand, they will ask you few things about Mallory-Weiss tear. First is tear is at the cardia. Most of the times. If the option of cardia is not there, next best option would be GE junction. Okay, अगर cardia option में नहीं है, then go for GE junction. What type of bleed is this? What type of bleed? What is the nature of the bleed? What is the nature of the bleed? Is it arterial? Is it venous? Is it capillary? Is it arterial? Is it venous? Is it capillary? Or is it any of the above? Let's see what Ria has to say to this. Is it an arterial bleed? Is it a venous bleed? Is it a capillary bleed? MKK artery. Datesh venous. Yeah, Ira, Ria, Nurel who has made many mistakes today, who normally never makes any mistake. Normally she is 10 on 10 student. नहीं सेकेंडरी नहीं पूछ रहा हूँ मैं, इसमें से ऑप्शन है, ये ऑप्शन है. इज इट एन आर्टेरियल ब्लीड, वीनस ब्लीड or it can be any. So normally somewhere here there is going to be injury. Venous. Okay, most of the time it is venous. Okay, my answer would be venous. It's never arterial. It is from the submucosal veins. It's a tear in the mucosa. It will be bleeding from the submucosal veins. Investigation of choice, of course, will be endoscopy. No doubt about it. Treatment. ये बताओ कोई. Treatment of Mallory-Weiss tear. How do you treat this? How do you treat Mallory-Weiss tear? अब बजी घंटी. या एनी आइडिया? कभी सुना है इसका ट्रीटमेंट? Confirmed on endoscopy, nothing else has to be done. How do you treat it? No, conservative is no treatment. ये कौन सी ट्रीटमेंट है कंजर्वेटिव? Give a more scientific term, conservative. ये क्या है conservative? One person following the other. It is usually self-limiting. Please say it like this. It is self-limiting. Usually when you do the endoscopy, the bleeding has stopped. It's never a major bleed. He will never have a lot of hematemesis. थोड़ा बहुत hematemesis होगा. Usually it is self-limiting. Okay. Rarely do you have to do any endoscopic intervention. Rare. Most of the times it stops on its own. Fine. That is your Mallory-Weiss tear. Hope you guys enjoyed some of the new things that you learned. Please go through my class that I took yesterday also. उसमें मैंने बहुत अच्छी upper GI चीजें की esophagus की. My next YouTube class is on Sunday. Tomorrow I'll be taking a special class. Tomorrow, special class. It will be either at 8 or 8:30. I will just publish it and share it. That will be again clinical questions, high yield topics. Okay, that is for tomorrow. So hope to see you guys tomorrow. GI part 3 is going to be on Sunday. Where is the common site of tear in bore half? Overall esophageal perforation. Overall spontaneous. I am saying spontaneous. Overall is in lower third because that is the weakest part. How is it differentiated from portal hypertension, hematemesis? Ira, you cannot ask things like that. In hematemesis, you'll see the varices, no? Those blue things which are bulging out. You see the varices. इसमें varice थोड़ी दिखेगा. इसमें खाली mucosa में tear दिखेगा. Yes, mainly 24 hours. I never thought it's done like that. Thank you, very good. Sir, daily class can be on Unacademy. Means what? I didn't get that question. Daily class can be on Unacademy means not on YouTube. I'll tell you what, Aisha, you can communicate with me on my Telegram link. So please add me on Telegram. This is my Telegram group where you can communicate with me whatever doubts you have. Okay, right? So then we'll understand each other better. And if you want to learn surgery on Plus comprehensively, this is a referral code 10 surgery that you need to apply. That will get you a 10% discount. Okay, thank you for joining me, guys. Do remember to like this video, do give it a thumbs up, and I am going to see you tomorrow for the special class. Okay, take care, guys. Have a good day. Study well, study hard.